call actionable strategy. I work across the landscape, with a variety of stakeholders, whether it's payers, providers, and that are working with payers and providers, and exit strategy development, business those clients. It is great to be back in Blackwood. It's great to be in person. You guys are social distancing. This is good. We're going to make it happen this week. It's awesome. But I'm also happy to facilitate this discussion. And I know we look like we're judges up here. It's not as casual as we hope. So don't let that fool you. We really want this to be an informal discussion. We have assembled a great group of experts in the field that can talk about why data is key when mastering value-based care. So in a moment, of course, we're going to get into your rights and their experience and how that merges themselves in your organization. But a little context, and I know for this group, you probably don't need it, but you don't have to do it, just to make sure we're all on the same page. But as you probably know, 1 in 3 Medicare beneficiaries has 4 or more conditions. Chronic conditions, right? So I know you guys are checking that off. We're going to do that a little bit every day. And only 6% of that population of those patients represent 75% of the cost. Right? Again, I know you guys are all into that data already. That's why you're here. Your organizations are here. And of course, that's similar in the commercial space as well. What's interesting though is that, of course, validates more of the need for us to think about how we manage care differently so that we can get to different cost quality outcomes. So again, you have to do that statement, right? You guys will do that. There's your signals as well. So this morning we worked with Dr. Taubman with the Village Medical Dean. And one of the ways he was discussing that we can improve cost and quality through value-based programs or services is to fundamentally change the way we deliver care, right? And to do that, we have to make good operational use of data, vast amounts of data. That's no new feat. The volume of data alone, just the sheer volume of data alone, can make that seem very possible. So for data scientists who really know to do that, it is a lot to get through. It's out of it and get actionable. Experts estimate that the healthcare data in the United States doubles every 3 days. It's a lot of incredible data is in the analytics. And by 2025, I thought this was interesting. The compound annual growth rate of data for healthcare will reach 36%. And that's faster than other industries like manufacturing, financial services, media, and entertainment. So healthcare is big. Healthcare data is even bigger, right? So even though that data may be big, and we're going to discuss how that data is key, how do we best harness it to deliver care or change the way we deliver care? And what's truly actionable, right? There's no silver bullet, but I know we're all in this room going, okay, yeah, let's get to the chase and what do we really need to focus in on and what programs and services can be deployed using that data. And also, let's be frank, let's not work, right? Let's not waste our time doing X, Y, and Z because it's just not yielding the results that we want. So we hope to have that kind of frank discussion with you guys today. So we're going to dig into it. We're going to have the panels introduce themselves. We're going to just jump into some questions and then kick it over to you guys for some additional questions that you might have with our group. Sound good? All right.
Sure. Yes. Welcome everyone. Thanks for joining us. I'm Trinh. I serve as CEO for the Villages Health. We're a multi-specialty group based in Villages, Florida, which is one of the fastest, largest adult living communities in the nation. We care for over 60,000 patients, 24,000 of them Medicare Advantage full risk, and have over 80 board certified physicians and about 140 clinicians.
I'm Dr. Randall Taubman. I'm the medical director of Trinh, which is a fairly new startup. It's a primary care MSO. It's a combination of affiliate practices, with about 25 affiliates, and about 8 wholly owned centers. Our centers are located in Miami, throughout Florida, Miami, Beach County, Hillsborough, and Tampa house. And we have about 6,000 managed care lives. We have, we work with about 10 Medicare Advantage plans. We work with ACO lives through Palm Beach ACO, and we do a commercial fee-for-service business as well. And I serve as a medical director. I do all the onboarding, patient engagement, physician education, outreach, and I also handle the utilization management.
Good afternoon, everyone. My name is Saini. I'm very happy to be here with all of you as well. And I feel a lot of what LeeAnn said earlier. It's good to be back and meeting people and having events like this. I've been fortunate to be part of these events since the beginning. My organization, Florida Accountable Care Services, was one of the first 27 ACOs in the country, and we continue to succeed and do better each year. And we've been at this program now for 10 years. We've saved a total of $150 million over our history. We've also saved another $50 million for our commercial partners. And we have, I guess, now 6 different ACOs, 3 Medicare ACOs, and 3 commercial ACOs. We also are involved with a small MSO as we delve more and more in full risk contracting. But we've been a part of this since the beginning. I've seen the evolution of this industry, of this acronym, as it's gone through the various changes in value-based care. Our organization is solely focused on the independent practice events, so all of our physicians are independent providers. They are their own businessmen and women. They make the decisions, we assist them. And they are all very, very, very different. And our approach to them are very, very different. One thing that is unifying is their willingness to look at data. Now, beyond looking at the data, that's where things get a little bit dicey. But I'm glad to talk about that as we go. Thank you.
All right, so let's jump into it. Is this on? Can you hear me good? All right, good. So, we're talking about data. So, I would like to know, what type of data are you actually using? And we can get into the program specifics, but, we have different representation across the board here in terms of givers and receivers, those who are trying to operationalize the data, those who are receiving the data. So, what type of data are you using, and in what way? Like, are you using the data to improve cost, quality, or target specific patients or populations? I'll start with whoever wants to go. Okay. We may get back to this.
So, okay, we're using data every day. We have several different teams. I think what's important, one of the things that's important with data is that you have good processes. There's several different components that one has to put in place to make use of the data. You have a good source of data, then you have to have a good process of what you're going to do with it, and then ultimately you've got to have actionable steps that are taken as part of that process. So, for example, I'm most involved in utilization. So we have census data that we're getting on a daily basis. We have census data coming from the ACO that we get through a specific app for the ACO. And we have a data backbone program that we're using for the Medicare Advantage data, and that captures all the ACO data too. So we push that data out, the census data out to physicians every day, so that they can then, at the physician level, off of the physician offices, they've got processes in place where they use their office managers, principally the office manager, and a call team, a call center, to schedule those patients back in. One of the things that we've pushed out in the last year is a robust TCM process for all of our patients within the Medicare Advantage and Medicare. In the TCM, the Transition Care Management Program, we've seen that go from about 50% TCM rate when we started to about 75%. There seems to be, there's a lot of things that kind of plateau out, and you have to figure out we're going to do to get it to the next level, which I'd like to see it get to 85% at least. And we're incorporating not only hospital follow-ups to that program, but the ER follow-ups as well. So that census data is something that's available to everybody through an ANS system. We capture it in this data platform I was talking about that gives us a lot of data points that we can then pick and choose which data we want to push out to physicians, which data that I don't want to review. Then I use that same census data to then generate referrals to case management. So we're a small organization, not using our own in-house case managers, which I'd like to, but we vendor out the case management to a company that does they do a home-based case management program where they are administering case management at the home level. These case managers are especially trained to also recognize medical problems. So they're not just case managers, social work, they also have this clinical platform where you have clinical-based questionnaires that you're using that can then drive patients with clinical problems back to the clinician quicker than they could be otherwise. So, and that's just one example of what we're using data on a daily basis. I think, there's opportunity other stuff there. It won't talk about the other areas.
Yeah, we'll get into more details on like utilization, just in general, the type of data that you're using in your organization.
Sure. So I think there's two sets that we use today. So one is risk score. Like I said, we use risk score accurately to complete. It's identify those members that have the highest risk of going to the hospital. And so, when you're an organization that has limited resources, you got to use data to identify who gets access to those limited resources. So that's one. Two is, a lot of folks here use claims data, and we use that as well. And it's more to analyze. I think there's three things that I use claims data for. One is I'm always getting contacted about opportunities and solutions and how to reduce medical expenses in population. Or two, I read a paper about different things that are happening. And so I use data to say the size of the opportunity because medical expenses are very complex, multiple ways you can look at it. But really, you want to go after the biggest opportunity first. So I use data to size the opportunity. Two, I use data to understand changes in MA. So when 2021, CMS is saying, hey, his or he is going to patients can enroll in any MA plan, and different plans were saying, hey, we run 100% plus on MLR. I became terrified because I'm just thinking about our own. But when we ran the data, we showed that we actually performed really well because our patients. And so instead of having to defer resources to our program, I said, well, our current care model did a great job of taking care of these sort of patients. I don't need to worry about that. Now we'll still monitor it, but I didn't have that fear of hundreds of ESRE patients enrolling into MA plans that we accepted, and obviously we're at risk. And then the third that I look at is that specialist group. Even though we're multi-specialty, there are a lot of the plans that we take, with those HMOs and open access network, meaning the patient can go see any specialist they want, even though it's an HMO, there's no referral required. And it's to identify specialty groups that really are overutilizing and compare as outliers. And so we identify those specialty groups and then try to create strategies to work on those specialty groups.
So for me, when we got involved in this whole affair, value-based care, the main question was, we don't know what we're doing. And in the beginning, we didn't get claims for CMS. We couldn't do it. We went to Kim's, we looked at different options, and we kept finding people who would come and sell us, wanted to sell us some sort of data analytics package that was built for an HMO. They just cross out 3 letters from ACL all the time. Here's your product, go ahead, buy that one. Or somebody had money back then either. So what we ended up doing is that we looked to our partners, and fortunately I see a lot of our clinical integration partners and our care partners in this room who provide us data. So we get claims data, we get clinical data from our physician EMRs, and and we get, data from our partners like, laboratory data. And all those things are very, very important. Because what we do is we pull in everything into a data repository that's constantly cross-checking and matching everybody's information. We also get EDT feeds from the state of Florida Health Information Exchange. We were one of the first people, on that. And so the national health issues, that's great. And, we kept pulling in, that's great. We also, had people trying to sell us how to get your Fitbit data and all these things. What are you going to do with all that nonsense? Because at a certain point, it's overload. But in reality, we'll be assuming sucking all that information, both claims, financial data and clinical data from the EMRs and things like that. We had to unify what we call patient master chart. We use that as the basis for our care management, care coordination across the board in what we do. We push that information down to our physicians, to our primary care physicians, to our specialists, and to our own team of care management, care coordinators who are all former medical graduates who are working in that space. But one of the things that was mentioned is keeping the different data. One of the biggest factors for us is, we get a specific type of report that we don't generate, that we get from one of our partners. And we mentioned we're sitting in the back of bus stops. They do a great job for us putting together data that we think is very, very actionable. So we actually go to a lot of our providers with this information because it shows, empirical evidence for what we, for actual opportunities in savings, actual opportunities in affecting quality of care, actual opportunities in reducing the cost of care. And if you can't synthesize all this nonsense into a couple of bite-sized things, you're never going to win because it's just overwhelming amount of data that you are exposed to, that you have access to, and that you can drown yourself in on a daily basis. It is a deluge. So it's very, very important to kind of, harmonize all the information coming into, to protect it, because I don't know if you guys have seen the amount of data breaches that are happening on a daily basis. I say this every day. Physician offices are soft targets. They're easily ripped up by anybody in the nefarious actors. So you really, really have to brush up on your data security policies and doing those kind of things. But if you don't synthesize that information into actual you're lost before you start.
Very good. So let's talk about those actions, because again, we talk about actionable insights all the time, and being able to employ this data into your practice or your business. So what specifically then, like, how could we characterize your utilization of that data? Whether it is, you mentioned reporting, are we talking about real time, at the point of care? So let's talk about the physical use of that.
Sure, I'll talk about one right now. It's discharge and transfer data that you get from the state of Florida Health Information Exchange, that ENS notification. That is something you get in real time. There you can dispatch your own hospitals if you have your own hospitals or online hospitals group that can work with your patients that are in hospital. You can get them seen quickly, you can get them discharged if they don't want to be there in the first place. And that's data points that are actually going to use to make a big difference. As we all know, how much of the cost is really taken up by your patient care. And then you do post-acute care, readmission. So when they're discharged, we know that. So we can send a team to go ahead and schedule that patient at a physician's office to see them when they leave the hospital. Otherwise, they'll falter for a few days in the doctor's office, like everybody's experiencing right now, is short-staffed because they can get $2 more working at Walgreens, CVS, or even Chick-fil-A than they can working at the front desk of a physician's office. So you have to put in some of these technology pieces and back office processes to overcome those, staffing shortfalls. But that data that you get, that's constantly going on. I mean, you need to have someone there who's processing that and acting on it. So one key example I would say is definitely those EDT feeds that you can get are from various health information exchanges.
So one way that we use data is to we implement a new process. We don't know if that new process is actually having its intended impact.
What type of process?
So one example was we implemented a new technology called InfoScience, and it would serve up HEC code at the point of care for our clinicians to address. And we thought we had a great process set up, and on a monthly reporting, it really identifies those clinicians that are following. So when everyone else is addressing 90% plus of these opportunities, like you've got a handful that are 20%. is about, monitoring the process and ensuring that, are we identifying outliers? Because you educate, you can train, but we all know that's not 100%. So I think using data nowadays helps us to ensure that we've got, best execution on the initiatives as possible.
So, the question is, what are the actual action steps, or what are you using the data for? Yeah. So, give one example before about the ENS and TCM visits. I'll give another example. Is along the lines of what Bob was saying, is that when the patient's coming in for a visit, it's very important that the pre-visit audit, we call it audit, when the pre-visit check is done to identify those care gaps. So we'll use HEDIS care gap reports. We try to incorporate that with the great model that I've work well, is to bring these together with the HCC care gap coding gaps. We just call them all gaps. Whether it's a quality gap or it's a diagnosis gap, I'm a big believer that there's still gaps and they can be lumped together. It's called all quality. That I'm a big believer that if a condition exists that's not being addressed, it's not just it's a clinical quality deficiency as well as a population health management deficiency. So I always feel that a condition is not going to be treated or patients not going to be educated on a condition, or the condition's not going to be treated if it's not on the radar screen, if the clinician's not addressing it or having it in front of him to address or thinking about addressing it. The chances that the clinician kind of did it anyway, if it wasn't documented, was probably pretty small. I'm not really a big believer that things happen and somehow don't get documented. I think that there's got to be a hand in glove relationship between what's actually done and what's documented. And if it's done, it's documented. If it's documented, it's done. And those things need to go together. The goal is to get every condition both recognized, addressed, treated, or at least educated upon, some monitoring or surveillance of that condition, appropriate treatment of that condition for every treatment, for every condition that exists in that patient. It's really the only way that we're going to get an accurate picture of CMS to secure the funding that's going to be needed for that healthcare. The healthcare is very expensive. There's going to be healthcare needs, and it's so important to get that healthcare, those dollars funded for.
All right, so let's talk about the ugly in the rigor, right? There's challenges, there's things that haven't worked very well, or things that have failed and tried, whether it's physician buy-in or patient engagement, whatever. Just what has been your biggest challenges with consuming and using data?
Sure. Okay, so what a challenge with data alone is the amount of data, how is the data doing something with it. So, like I said, we get a lot of data from different sources, and not always good. Everyone says that HL7 connectivity, they have this API that connect each other, but the data they get in there is half its garbage. It doesn't cross-check with each other. You can't actually match, the same patient have the same thing, but it's 10 different people. It just doesn't work. So you have to get the garbage and then noise that's in there. The next thing is, if you have multiple pairs, you have the same kind of report, but it looks 10 different ways, with a couple of different pairs. So you have to harmonize all that information, because at the end of the day, there's humans on your team who are looking at this stuff and they don't understand it. So definitely work with your payer partners to get them to make the reports, or to give you flat file information so you can make it look the way you can actually understand it. The other obstacle, once you get it all in, is that we do it. So our organization is made up of independent physicians, and so we don't know them, we don't tell them what to do, we're not their boss. We're part form. And so we provide some reports, and some of those folks will take those reports and do things with them. Some will look at those reports and you can go back to their office, and their report from last month is sitting on the desk with their report from the month before, and then it's moved on the desk.
This
Exactly. So you just have to figure out what motivates each one of those practices, how do you incentivize those practices on an ongoing basis. Remember, at the end of the day, the payment model that we're in is that, you start in January, maybe you win the following year. You don't even know if you won until, August, and you don't get paid until October or November. So you're in 2 years before you see any real change, and you have to keep people motivated along this way. So you have to figure out ways of incentivizing them to do those things that you need on a regular basis, right from the get-go. Because otherwise, the run up to actually earning money and being successful is so long that people just kind of, they're more happy to leave and lose interest because, it's hard, because for ACOs, remember, you're getting paid already for the services they can perform. So this is enormous money, but you have to kind of change that conversation and do what you're doing along the way to give those people an incentive. So one of the things that we work with is providing incentives to staff and providing incentives to office managers and things like that, because, for looking at those reports and doing things with them, because at the end of the day, they're the ones doing the work. They're the ones actually effectively changing the office. You can go and have provider meetings, day in, day out, go to fancy hotels and steakhouses and all that, but it's not going to change what happens in the office if on Monday morning there's one less body working in that office, and the office manager goes and says, "Hey, I'm already stretching that you want me to do this now. Give me a break." So you have to take that. The challenge is processing data. It's also using actual people and figuring out ways individually with your offices. Doesn't have to put the job because you've got employed folks who can do it, and they can create a lot of burns, but it's harder on like onesie twosie offices. They really just don't have that level of that. And so it's tough to get them to understand the value of those.
Do you have a specific failure, like one of those things that you thought was going to make the biggest difference?
Oh,
You didn't hold
absolutely.
it out, and that was a big flop.
No, absolutely. We thought, annual business will get you that information, who had that done, and do it. And, there was a lot of third-party companies that came out and say, "Hey, we'll do your annual business. You're going to make another $30,000, $40,000, $50,000 a year. You're going to bring us those faxes, those emails with, those little calculations and show it." And all the physicians said, "No, we're going to do it ourselves." That was we don't want to give up our individual pots of gold. We give them the data, we look at it at the end of the quarter, at the end of the year. They didn't do anything more than they did the year before. So just providing data on any wellness visits and their information was not enough. We had to start doing things like scheduling before that, getting out and doing it. Because at the end of the day, the issue was still the same. We just didn't have the motivation for the people to do that.
Guys.
So I'd say there are two things in our organization, in addition to, what Vic said, all of them very experienced in it. Two things that I have is, we learned some shared savings with some partners on very specific state programs. And I think it's getting both sides agree on how to use data. And so, for example, so we want to first identify the right patients that should be in the program. And we also want to identify the right baseline of that cost, because we're going to be sharing the surplus, and I always tell all my partners, it's successful. I don't want to overpay for something that really that savings was going to happen with, because we overestimated what the cost trigger was going to be, et cetera. At the same time, I want to make sure they're fairly compensated, because if they're providing the service, it's got to be a win-win. So that's one is. And I've had this where I'm working with organizations, this goes back and forth in terms of trying to interpret the same data set to ensure the right patients with the right baselines are calculated so that it's a fair agreement. That's one. Two is just develop on teams. So, we have this data, we're on the board, but some of us we're up to 10 people, and there's nothing in there that tells me what the aha is. So what you have is like 10 different people have an open report, trying to figure out what the headings report says, and really trying to understand what the aha, getting my team, whoever's generating reports, to analyze it first, give whatever the aha from the report is, so that, save 10 people's time in terms of, so those will be
budget more as a clinical, clinical program. It was my mind went there to think about clinical programs that haven't worked well. And of course, this clinical program is based on data referrals, or using data to make those referrals into it. And I think in our keynote address this morning, there was a mention of home-based programs. I'm a big believer of that. I think that getting clinicians into the home or some care providers into the home is a great idea, and that can really help elucidate new problems and solving problems. But I think one of the challenges there is what kind of provider you put into the home. So one program that looks really great in theory, and maybe some of you are using a program like this, I think this type of thing sounds really great, has a lot of great promise, and that is a nurse paired with a clinician, with a doctor. The nurse was in the home, the doctor was remote. Anybody using a program like that, a nurse paired with a doctor in the home environment? No, well, we used a company that was doing this, and it sounds like a great idea, but and then I was using as I said before, some of my utilization data, my hospital census data, hospital discharge data, and the diagnosis that those patients had, hospital frequency data to help drive those most appropriate referrals into that program. But some of the drawbacks, some of the problems we had was because we had doctors taking care of those patients, we're not the PCP doctors. These were doctors that would be available nights and weekends and off time, which sounds like a perfect solution, right? When the PCP wasn't available or wasn't really maybe engaged to handle a phone call the way we would want them to, you have somebody who's on, not just on call, but on duty, so to speak. These were ER physicians that I guess have some special training to kind of redirect our efforts into the home environment. So I'm not a different program, and yet our physicians kind of recoiled or resisted having another clinician step in and take care of their patient, even if it was just for a day or a weekend. They didn't always agree with the treatments done. And the cost, I'll get to the cost of the program, but because it involved doctors, the cost was too high on a weekly basis to then cost versus the benefit. The benefit outweighed the cost savings, outweighed the cost of the program, then the cost of the program wouldn't matter if the cost savings was greater. It didn't turn out to be so. So I went with a program that used, as I said before, the case managers, who then had the program clinical training, seemed to be a more cost-effective way to go for risk-based patients.
Good. So trial and error, of course, practicing medicine, practicing using data is something that we're continuously learning. And then the ecosystem, obviously, there's so much to stitch together, and there isn't one model, right? That's one work for every organization. But being able to actually use that and make it operational, going back to your process, right? That you have to fundamentally change the way you do business to incorporate this data or deliver care. All right, so rapid fire, we're running out of time, but just real quick response. What is that next big thing that you're thinking about or you're currently looking into that you think is going to hold some good promise in how you manage your practices or your care?
One, security.
That's still a little bit.
Yeah, security.
Okay.
Security. You can't say enough things security. We have more and more information to do with more opportunities to move that to the various sectors. So we have more security. It's an area that a lot of physicians, let's be honest, physicians who work in hospital systems, large folks, they understand compliance and they have a compliance department. As soon as the physicians open up their own office, compliance is like the last thing on the list. They have so many things to deal with. So when it comes to information security, that is a big issue for me right now, only because there's, like I said, there's a it's the Florida information equivalent, and that has information there, like the driver's license that can be used as information. You know, so you have to watch it out. Like I said, physician offices are star targets.
First of all, that's something what I didn't know about fitness, so I gotta go back and show my team about this thing. So I would say we're about to launch a pilot to our care center with 6 of them, or now 7. It's called Norflow, so you know they say that those patients that have behavioral issues are free costs, higher medical expenses. So we're tipping our toe into digital health. You know, I've always been a question mark about digital health because that sounds great, but it doesn't really produce what it says. So we're going to try this where all of our primary care members patients will have this app, and hopefully it'll engage them, and we hope that for that patient population it's going to reduce their medical expenses, which really means less of our visits, less admissions.
Yeah, that sounds like a good program.
Yes.
So for mine, well, it's hard to know what is the next big thing. You can't see the future, can't predict the future. But one of the things I'll just give something that we're trying now, that we're going to launch very soon, is pharmacy, remote pharmacy consultation. Is having those clinicians, they can generate pharmacy-specific recommendations to the clinician, but they can also engage one-on-one with the patients remotely through the phone and do pharmacy consultations to the patient. Those pharmacy consultations can center around things like Medicare, which is, you know, a very challenging aspect of patient safety, HEDIS measures. They can focus around drug cost to the patient, staying on formulary and low tier, using generics where appropriate. They can target things like drug interactions, such as maybe speed measures moving down the pipe, and opiates versus benzos used concurrently. We want to be able to minimize these negative interactions such as that.
Sounds like consistently, security is part of it too, but there seems to be a LeeAnn or to that direct patient program. You know, so using the data to get to that discrete point of care at the right time, right? All right, so we are out of time, but I really would like to open it up just for a few questions if you guys have something burning.
Thanks for your presentation today. Really enjoyed it. Quick question for you. You talked about harmonizing the data that you receive from multiple sources and different payers. I'd love to hear a little bit more about what are your favorite or preferred tools and methods for aggregating that data so that you have a unified view for the physicians, so that they don't have 10 different scorecards, for example.
I'll take it now. Thank you for the question. So we prefer to get flat files from all of our payer partners and utilize that so that we can put it in our own system to create our own reports that go to the physicians. What we get from the payers is data that kind of sells to us as the CEO administrators and plan administrators, but not necessarily what the physician wants to see a consistent for what they do. So we pull all that data and we create those individualized practice reports for provider and then also for office manager or the clinical value-based person in the office and kind of always be able to make sure we have leadership or something like that. So we have 2 different levels that we do because we don't pass on the data we get, in the law or even prepare reports for slide presentations because they can lose themselves in the weeds of something that has nothing to do with what they actually need there. So people affect change process. So we go over and harmonize them. That's why that cadence of data from payers is very, very important to us so that we're getting that and then we're pushing that and we're having our follow-up. So it's got to have that. So that's what getting to that, harmonizing the data with the other data. So we pull with your payer data, but then we also get the data from the physician offices. And so that clinical data goes, no, I that, we get to go and test it or something. So we get a lot of opportunities for discussion, and it's based upon information.
No, I would agree 100% that you have to synthesize the data into a single report.
Questions? More questions?
I'm loud enough, it's okay. So what we found is providers receiving data is great to see their own reports, but what we found very beneficial is when providers are not only able to see theirs, but compare it to how others are performing as well. Because we're very competitive, it's in our nature. And so I'll drive myself to more success if I know that I'm not performing as well, so it'll drive me higher. What have been your experiences on sharing not just their own data, but comparing them to other providers?
In our person, because we have independent physicians of ours, we did that for a while, but we showed everybody at the end of the year, here's their log, here's their log for this. And it does, we wanted to take a look at that nature that's brought into physicians before they even got to medical school. Right? They judge against each other, grade against each other their entire career. So we did that. And then we also changed our payment methodology. We got shares in. We put a fund that, everybody who did bad, we pulling courses of their quality, putting into that fund. And from that fund, the merit fund, if you want to call it, we took that money and we gave that to people who were doing very well, improved, things like that to help incentivize them and do their thing. We try to write things, balance seems to work the best. At the end of the day, people want to be incentivized to do better. They just want to see a clear pattern and model. Show me how I can do it so I can actually learn that. And that's been the most successful. And that's just not really from the providers. I try to get individual offices to do that with their staff. Their medical assistants spend more time with them than the providers. Their staff is the most important people. It's their smiles that get in that capsule. It's their, that's the end of the day. So you have to trickle out all the way down to the front desk to say, okay, listen, this is our report of how many missed calls that we have. You get that report down, we're going to give you this much more. We're going to give you this, not as a one-time bonus at the end of the year. Frankly, everybody expects a Christmas bonus or every year bonus, but they don't know if you have a system where every month that they can get a portion of something that they're getting, eventually, it's a big difference. $20 is a big difference maker. It's not. $100 is a big difference maker. You just got to find the right switch for each person.
I would just add that would be something similar. So we'll have team this, team whatever. So we do it, obviously it's the physician and the team is posted in the break room. So all the teams can see how they're doing. And we found that it's very effective in making a team effort versus
Yeah, I would agree with what Bob was saying too on the team aspect and hold the team accountable. And of course, the pros and cons. I think the pros outweigh the cons in terms of comparisons, but of course you have to normalize the data so that it is comparable. It can be compared. For pushback, some physicians might say, well, I'm much busier or that's a different location. So you have to be kind of sensitive to the physician issues that the physicians might arrive or come up with. But when you're looking at the data, you're looking for people who are geographically similar or close by. I think that helps. Look for doctors who are similar in other ways, so you're comparing similar docs as opposed to just similar. Those are the only caveats that go out.
So thank you all for sharing. This has been really insightful. My question is, I understand that a comprehensive data set is being used for things like pre-visit planning and scorecard distribution, reporting, and so on. But I'm curious, how is the data, this comprehensive data set, being used at the point of care when the patient is in the room with the provider or the clinician?
Yeah, a lot of offices tell it's not being used. They just don't have the time and so it's mostly generated and bringing before the patient, before the provider walks in the room. Everybody has already removed that patient who's gone through having a routine that they're up or is taking care of something like that. We'll also try to do APPs call and see if you want to cost to pay for those encounters, but you're not going to get much. It's going to probably be that 30 second to 5 minute visit that they're having. Like, really, they're catching what they need from those encounters. I mean, I'm a firm believer in getting rid of screens in front of doctors. They're looking at the screen and not looking at you. Definitely not touching you in a good way. And so, it doesn't, so for me, it's almost
The data has to be comprised into, it can't just be raw data from that. It has to be put into a format in which the clinician can use it. I've seen it done very well with the example I was talking about before, the gap report. They give specific gaps that are missing, and then the clinician can use that. Or, as I said before, the census data of patients that are missing. Currently in the hospital, discharge, combination in the hospital, discharge, then it can be used, but the data has to be synthesized into a usable